I'm going to admit all. Hi, everyone. Thank you for joining us today. It is 12:58, and we will begin shortly at 1 o'clock. All right. It is 1 o'clock, so we will get started. Good afternoon, everyone. My name is Chao Wen, and I'm joined today by my education co-chair, Denise Parr. Welcome to the APIC Great Lakes 2024 Educational Webinar Series. This month's speakers are from the Michigan Department of Health and Human Services Infection Prevention Resource and Assessment Team, also known as IPRAT. They will be discussing their long-term care and healthcare associated infection reduction programs, including their common findings from their observations. To ensure that we can all benefit from this webinar, please keep your line on mute and not hold. Putting your line on hold may play a message or music disrupting the webinar. If you have any questions during the presentation, please drop it in the chat so that we may ensure your question is brought forward during the Q&A portion of the webinar. No continuing education is available for this webinar. And with that, I would like to introduce our two speakers today. Christine White received her master's in public health and epidemiology at Benedictine University in 2019. She earned her CBIC certification in infection control in 2022 and her long-term care certification in infection prevention in 2023. She is also certified in diversity, equity, and inclusion in the workplace. Christine joined the IPRAT unit in October of 2020 and as an infection preventionist supporting long-term care, acute care, and congregate settings. Our second speaker is Chelsea Ludington. Chelsea received her master's in public health and epidemiology at Grand Valley State University in 2016. She earned her CBIC certification in infection control in 2020 and is active in APIC Great Lakes as the 2023 nomination committee chair and an APIC national conference presenter. Chelsea joined the IPRAT unit in October of 2020 as an infection preventionist, became the IP team lead in November 2021, and in 2023, she became the manager of the IPRAT unit. So with that, welcome Christine and Chelsea, and the floor is all yours.
Thank you so much, Chow. It's great to be here. Welcome, everybody. I hope you're having a good afternoon so far. So yeah, we will go ahead and get right into it. So we will be talking about both of our long-term care project and the healthcare associated infection reduction programs. Next slide, please. Our objectives for today, like I just said, we'll be going over both of the programs that are outlined here and the common themes that are associated with each. Next slide, please. Before diving into those projects, I did want to talk about exactly what we do at IPRAT. And so the first thing is that really making sure that we are non-regulatory or a free consultative service, and then that we are available to offer both remote and on-site assistance. So we can have discussions virtually, we're available for emails, but then we're also available to come to your facility and be able to help you in whatever ways you need for infection prevention. And our overall goal is to assist congregate care settings in areas of infection prevention. And we do provide education in a variety of ways while on site visits. So we do in the moment education with individuals. We also have educational sessions that we have several that are already on my train, and then trying to do, if you reach out to us via email, we'll be able to get you information that way as well. And then another thing that we would do is if you would like us to look at your policies and procedures, we can review those for you as well. Next slide, please. We have three main overarching goals within our unit. And the first is to prevent outbreaks of infection. And this is spanning 4 communicable diseases across the board. So looking at things like COVID-19, our nosocomial infections like CODIs, MDROs, and then norovirus, just to name a few. Our second goal is that we do know that infections happen. So when they do, we want to make sure that we contain those infections and the spread of the disease throughout any residents or patients in the facility. And we do that by providing guidance on how to prevent transmission. The final goal that we have is to educate facilities infection prevention strategies to mitigate the risk of future outbreaks. And the practices and topics that we educate on will then help prevent and contain all of the pathogens in the future. Next slide, please. So this one gives you a better outline of where we end up falling within MDHHS. And we have had quite a bit of change recently. The first is that the Bureau of Infectious Disease Prevention recently undergone some restructuring and split into 4 divisions. So we have the Communicable Disease Division. That's where our unit used to fall. We have immunizations, we have data systems and operations, and we have emerging infectious disease. Within our division, that's the new division of emerging and infectious disease, we have 3 sections. So we have hepatitis and TB, we have emerging and zoonotic diseases, and then we have healthcare associated infection section, which is so exciting because this is brand new. I'm thrilled that we've been able to get this within the state. And so and then really, really new, we have 3 new units. And so of course, IPRAT has been around since 2020. I'm sure you all have heard of SHARP, but rather than being, it's continuing to be its own unit, but we are also, it's going to be more collaborative across the section, and that's where our epidemiologists are going to be housed. And then we also have the MDRO containment unit. And so these 2 are, we have 2 new unit managers for those areas. And then our section manager is Brenda Brennan. I'm sure many of you have heard of her, so we're excited to have her leading us within this section. Next slide, please. Kind of diving back into IPRAT, as said earlier, I'm their unit manager. Denise Parr, who is also on this call as the co-chair for education, is our HAI outbreak and dialysis lead. Christine White, who you'll be hearing from shortly, is our long-term care lead. We have Michael leading our statewide HAI reduction project, and then My Echo is our local health department project that we have as a collaborative, is being led by Alex Udetskia. And then we have several nurse consultants on our team, including Keith, Nova, and Andrea. And we really do try to make sure that within our section now, we'll be strongly collaborating between the SHARP unit and our MDRO containment unit. And the map here just shows an outline. This is somewhat outdated, but the purpose is really to show you that we do travel all across the state. And we're available anywhere that you may need us in Michigan. Next slide, please. Thank you. So here we have listed the diverse congregate settings that we serve in IPRAT. And so whether you're trying to reduce your facility's healthcare associated infection rate, review your infection prevention program, or mitigate the spread of infection during outbreak, we are here to provide support. And so with that, I'm going to turn it over to Christine to talk about our long-term care project.
Thank you, Chelsea. I appreciate that. Excuse me. This weather is making my voice froggy, so I'm going to have to be taking sips of water just occasionally. So I apologize. I want to go ahead and get started talking about our long-term care project background and description, just to give you an overview of what that means, what that consists of within IPRAT. So some of you may be familiar, and for those that don't know, our long-term care program was established in October 2020 in answer to the pandemic to help with long-term care settings, which we know were historically underserved regarding guidance and prevention to help them through the pandemic. So that's where we came into play. And we often, with that, was providing targeted IPC guidance, staff education, and mitigation strategies in response to the pandemic. Historically, our on-site team would consist of a data analyst, nurse consultant, and infection preventionist. And our program deliverables would include an action plan that had our observations, recommendations, and resources. And we had them in based on risk level, and also would include a facility data report and an SBAR. Next slide, please. So through our project scope, we did a little bit of changes to that based on our the inclusion of our new teams and divisions to just have a better sense of our focus and what we're going to do and how to help facilities. So due to that restructuring of the IPRAT programs team, we found it was necessary to narrow the scope of the LTC program services while continuing to incorporate DEI principles. The proposed new scope consists of providing LTCs with focused services. So we're still going to do that facility ICAR. We're still going to we're including now IP mentoring, risk assessment, and IPC annual plan guidance. Because we've noticed, especially since, and you probably have noticed this some in your settings too, there's a lot of newer IPs in their roles. And that's why we felt it was very important to include the IP mentoring and take them under our wing and provide as much support as possible. And also noticing there's still some knowledge gaps regarding how to do a risk assessment and an IPC annual plan. So we felt that was important to incorporate into our program. Outbreak support is transitioning to virtual phone and email, except for emergent on-site requests, and staff education is transitioning to a more virtual platform via recorded webinars. Next slide, please. Common themes. All right, let's get into it. This is what I am seeing, my teammates are seeing when we are out and about in the field. Just to raise awareness. And please keep in mind, if any of these come up and you happen to notice them in your facility and you need resources, please do not hesitate to reach out to us. You can ask questions in the chat, and we will get you the tools that you need to make sure that you can improve your practice in your facility. One of them I'm seeing a lot of is lack of antibiotic stewardship program, either not having a program at all and or having a very shaky one. And not having a lot of buy-in and needing some support there. We do also have a team within the division that can help. We have Ann Haddad who helps with antibiotic stewardship, and we also have a peer provider that can help with having some of those more difficult conversations that can happen with some of our providers that might have a habit of wanting to prescribe inappropriately for those antibiotics. So if there's any resources that you need regarding that, we can link you with either of those individuals. The other was no risk assessment, as I said earlier, either no risk assessment or annual IPC plan completed, or thinking they don't have to do priorities, risks, or goals, or understanding the need to do that. I have seen some that just look like an assessment literally of what's on site, but there's no established risks or goals or anything. And those are really, really important. We need to be aware of what's going around in our environment and our settings so we can be prepared. And talking about the risk assessment and annual plan, that's a living document that changes every year, and we should be updating it accordingly. And again, if that's something you need help with or you struggle with, we have some really good resources. Please don't hesitate to reach out to us. The next one is very common and might give you some eeks, but I see it a lot. Sharing nail clippers amongst residents and not performing proper disinfection between use. This is a caveat too, being mindful that 9 times out of 10, these aren't meant to be, shared anyway. They're usually disposable, so they're not going to have cleaning and disinfection instructions on them. So that's another caveat that has to be addressed. But at minimum, they should not be shared between residents, and they should have their own pair. Next slide, please. This is my I Spy picture. I like to take a lot of pictures on site and share them, and they're really, really good teaching tools. I encourage you, if you don't use this tool, I encourage you to incorporate this. This is really great to educate staff. Right away, I'm sure you can all see, we've got some nail clippers chilling in the sink, which big no-no. I don't know what was happening. I thought they were gonna clean them or soak them in some water. I'm not really sure. And you can also see in the same area, there were a stack of washcloths being stored on the sink next to the lip, unprotected. We also have an unlabeled or an undated disinfectant spray in the back, so no idea when it was prepared and if it's still fresh or not. And you can see in the left picture, just kind of off to the side on the right, we've got a little personal beverage, their little Yeti chilling there too. So this is definitely one of those areas where we're going to provide education to staff. This was in a bathing room, shower room. We're going to provide some education to staff regarding how this is not best practice and why it's not best practice, and explaining what should be done. Next slide, please. I am encountering a lot of bath aids using nippers on residents to help with their nail care. I would highly, highly, highly discourage this practice. You see how sharp they are. You see that there's a definite risk. These are going to come in contact with non-intact skin and mucosal membranes, which means they're going to require high-level disinfection. And the long-term care facilities do not have the capability to do high-level disinfection. So this is a practice that I would reserve for our podiatrists to take care of due to the potential risk of injury. And these aides are not receiving proper training on how to utilize these nippers. So just be aware and find out if these are, when I asked leaders, they would say, oh no, we're not using those. And then I would find them in cupboards. So make sure when you're doing your rounding your environment of care, make sure you're looking in those cupboards and opening them in there and seeing what's actually being used. So this is just an example of what those nippers look like. They are called nippers. And I will, just for background, there was a large outbreak associated to a podiatrist that was using nippers on multiple residents, and they were not high-level disinfecting in between. They were just wiping them with an alcohol pad. It was a HEP outbreak, so just be mindful of that. Next slide, please. So another thing that's pretty common is not understanding, going back to talking about the nail clippers and the nippers and things, staff not understanding the difference between reusable and disposable items. So they're trying to basically clean and disinfect a disposable item and not really understanding what that concept is. So we need to make sure we educate that if they're not cleaning and disinfection instructions on that item packaging, then that means it's disposable and what that means. And that specifically should be dedicated, if at all possible, to one resident. That ties along with our next common theme, lack of knowledge for low-level and high-level disinfection. Again, a lot of settings are going to be limited on their ability to do a lot of high-level disinfection. So we need to be really, really mindful of the, if we're using any semi-critical devices in those settings, can you properly high-level disinfect them? If not, then you need to really consider removing them from that space and using disposable. And what the difference means, for low level. Like I have ran into a lot of staff that think wiping an item with an alcohol pad is sufficient when we know it is not. Not disinfecting glucometers between use. This one is pretty common, especially the smaller units that we see. They just think that it's not really going to come in contact with blood too much, so they don't think they need to disinfect it, and they just want to go ahead and put it back in the case. So we need to make sure that we're educating them and following manufacturer's instructions per use regarding how to disinfect those glucometers. Next slide, please. Again, following in that theme, not disinfecting insulin pens between use. I have observed it. Where they, provide the insulin and then back into the med cart. No disinfection happening, and or piling them all together on top of each other. No disinfection happening. So we need to make sure that we educate them, and that's again going to be following your manufacturer's instructions for use regarding that specific pen, because they may, vary depending on what product can be used on those. Getting in our food code area. Not dating, timing applesauce or pudding after opening and not storing them on ice. I see it pretty commonly where applesauce container will be open and just sitting on top of the med cart and or pudding. And also sometimes the nutritional shakes, seeing those open and just sitting there. Once they are opened, they have to be dated in time. They have to be kept on ice. There's a 2-hour window where they're no longer good anymore and they have to be discarded. So we have to be mindful of that. That does fall under your food code and that potential for GI illness and foodborne illness. So we need to be mindful of that. Staff belongings are food and medication storage and prep areas. This is a multi-pronged issue because it usually what I'm seeing is because the staff don't have a proper area to store their items. So if you're having this come up constantly in your facility, trying to brainstorm ideas of a better place for staff to store their personal belongings and food, and also making sure that there's not an issue of theft, and that's one of the concerns, and maybe that's why staff are feeling like they have to hide it. So just be mindful and educate them that they need to understand that the medication storage and prep areas are considered a clean environment. There should be no form of contamination or potential cross-contamination in there, and that's why they cannot store those items there. Next slide, please. So here's another I Spy for you that was observed. Quite a few things going on here. We've got our linens not being covered. We've got a scrub jacket stored on top. We've got some yummy lunch in there going on. We've got some takeout and we've got a beverage in there. I like how they at least had the straw folded into the drink, but still. So obviously this is a big no-no. So we need to educate them that our linens are meant to be kept clean and sanitary to be used for our residents. So we want to educate them on that they can absolutely not store food, drink, beverages, personal items in this area. Next slide, please. Another thing I still come across this, which I'm still surprised because I know we have an abundance plethora of those face shields. I am still seeing the clean and dirty bins. We need to make sure that, first of all, if you have more than ample supply of those face shields, you should not be reusing those because that's basically saying that you are functioning at like critical, essentially, that you're having to reuse because you don't have enough, and you'd have to show that and have proof of that with your PPE calculator to show that you have to reuse those. If it shows that you don't need to reuse them, then you get cited. So we need to be mindful of that. Not to mention the fact that foam on those face shields, because what's happening is these are being reused by other staff. They weren't designated to one staff. Those foam cannot be disinfected properly, clean and disinfected. Would you clarify if your message is to disinfect insulin pens between use or on the same patient? If that disinfectant pen's getting put in that med cart with the others and touching each other, that's the reason for that thought, is why it should be clean and disinfected between use. And it's going back into that med cart. That med cart is considered a clean environment. So we should be disinfecting it per manufacturer's guidance. Hopefully that helps answer your question. And I can't see too much of the chat right now. I just happened to see that when it popped up to address it. Washing and reusing orthopedic boots, hand splits, povo boots, etc. This is very common. I see this a lot. Please note, based on the manufacturer's instructions for use, these are one and done. They are for that work. They're only meant for that resident. They are, you cannot properly disinfect them. We say, yeah, we washed them, but we know that individuals can have skin issues. Fluid can leak into these. You cannot properly disinfect them. So those orthopedic boots, hand splits, povo boots, etc., those are meant for that resident and that resident only. And when they're no longer used, they should be discarded. Next slide, please. That's just an example. So these are examples of some of those povo boots and the manufacturers that you can reach out to. But it's like also like that one on the right has Velcro. You can't properly disinfect that. They get worn out. So we need to just be mindful of it. I do see it a lot. And it's just not best practice. They're not supposed to be used for more than one resident. Next slide, please. This just came out for those that are not aware. We want to make sure that you saw this. This is regarding a CMS QSO that came out on the 20th regarding enhanced barrier precautions, and that this is going to start being part of the survey process. So we don't want anyone to be blindsided. Please be aware of this. My understanding, this is going to go into effect April 1st. If anybody has any questions about enhanced barrier precautions, you need any guidance or education, please reach out to us. We do have my echo that was done that we can share that's on my train. We also highly recommend using the CDC enhanced barrier precaution signage. It's very, very well done. It very explicitly explains to you what situations and scenarios you would need to practice these. But please be mindful, this is going to come into play and it's going to be as of April 1st. And I am going to mute myself and go ahead and turn it over to Chelsea, unless there's any questions that I can answer. Or did you want to wait till the end, Chelsea?
I think we can answer long-term care questions right now if you'd like.
Okay. I can't see the chat right now. So if anybody has any, please let me pull that up.
It looks like we're good
Okay.
for now. And there'll be time
All
at
right.
the end, of course, too.
Thank you.
Thanks, Christine. All right, so moving away from the long-term care project and into our statewide HAI reduction program. So here you can see our mission and vision statements. So with our mission, with our statewide HAI reduction project, we'll use a collaborative data-driven approach to decrease healthcare-associated infections, also known as HAIs, in Michigan acute and critical access hospitals, and improve equitable health outcomes by promoting and providing resources and education to their infection prevention programs. With our vision, it's short and sweet, is to reduce HAIs within Michigan's healthcare continuum. Next slide, please. So this one just shows you where our data comes from. And we do receive our data from NHSN, from our sister unit at Sharp. The selection of facilities for data-driven outreach depend on the established SAR target for the particular HAI that we're looking at. So we do pull based on if we want to get information on our CLABSIs, CAUTI, so on and so forth. And we also reach out to hospitals we have an established working relationship with, based on whatever we may have talked with them about in the past. And know quite a few hospitals that we reach out to, maybe about their CLABSI rates, ends up transitioning, and we can work with them in the future for something like device reprocessing. Next slide, please. So this is a very brief outline of what our process looks like with our facilities for this project. And the first thing is that we will do the outreach to your facility based on either our NHSN data or prior interest in our services. And then from there, we'll get some sort of introductory information so we can help ourselves better guide on what information to get to you. If we do decide on a site visit between discussion with you and ourselves, we'll work with you on scheduling that and conduct either a comprehensive or a focused assessment. And please keep in mind too that our main goal isn't a site visit. If that's something that doesn't work with what we're trying to discuss, we're also here as a virtual resource and available to collaborate with you and help you answer your IP related questions. And so that can be through email, and we can have meetings, things like that. If we do end up coming on site, we would then put together a report based on your on-site observations and include recommendations and resources based on what we saw while we were there. And these reports include an infection prevention program assessment report and then a high-level summary. And then we also provide ongoing support through following up with facilities and providing guidance through our team's inbox. And we'll drop what our inbox is here within the chat shortly. Next slide, please. So something that we do look at, regardless of why we are on site, is the infection prevention program infrastructure. So that's, of course, going to be the foundation of whatever we're there for. So whether it be helping you with CLABSI or CAUTI, we want to make sure that the foundation of the program is there. And that will end up helping to support that comprehensive and robust infection prevention program. And in addition to assessing a program's risk assessment, plan, evaluation, and surveillance systems, we also look at the education and auditing programs for things like hand hygiene, PPE, and other topics based on the type of assessment. And we can also, like I said earlier, look at your policies and procedures to make sure that they are in alignment with evidence-based practice. Next slide, please. So this just shows you where we've been. This project started in the beginning of 2020, and it did come out in sequence. So we started with looking at C. diff, and then we ended up transitioning to CAUTI, and then I'm forgetting if it was CLABSI and device reprocessing, but they came out sequentially. So since 2022, we've done 39 HAI reduction site visits. And as we go through the rest of the presentation, I'll break down those individually. Except for CAUTI, because I didn't want to have just a graph of one for CAUTI, but the CAUTI visit was for one of our long-term care facilities. And we're still available to check out your CAUTI reduction program if you need us there. Next slide, please. So the first part of the project I want to talk about was CLABSI elimination or reduction. And so for CLABSI, along with that program infrastructure I talked about earlier, we complete a comprehensive assessment of central line insertion and maintenance practices. So for the line insertion and maintenance, we look at your educational program for all personnel who insert and maintain those central lines and auditing programs. If your facility has concerns specific to dialysis lines, we also have a dialysis assessment service that evaluates IP practices from dialysis startup to takedown, and then the maintenance of dialysis lines in between. Next slide, please. So here is where we've been for our CLABSI visits, mainly within our acute care facilities, and then we've done one within an LTAC. So 15 in total since 2022. And yeah, I guess that's it for this slide. Next, please. The next part of the project I wanted to talk about was our device reprocessing program. And this is dedicated to the assessment of systems and processes surrounding semi-critical and critical device reprocessing from point of use, pre-treatment to the storage, and then all the steps in between. And this is not limited to just surgery or central processing or endoscopy departments. We do want to look at your, we're available, I should say, to look at high-level disinfection and sterilization throughout your hospital, including areas like cardiology, radiology, within the NICU, and then your associated outpatient areas such as OBGYN, ENT, and urology clinics. So available to look basically wherever you need us for those sterilization and high-level disinfection. Within this area, we have done 14 site visits, helping those in acute care, a provider office, and then a human product donation facility. Next slide, please. We also help with CDI elimination. And so looking at those areas that are listed on the slides, like barrier precautions, hand hygiene, cleaning and disinfection, and then antibiotic and diagnostic stewardship. We also look at C. diff testing algorithms and protocols. And then the recommendations that we provide to facilities are aimed at early detection of community onset C. diff lab ID events and the prevention of C. diff transmission. Next slide. Thank you. So within this one, it flips a little bit from what some of the other areas that we've done within this program, with being more, having more interest of us coming on site within our skilled nursing facilities, but we've done 12 of these so far. Next slide. And finally, talking about CAUTI elimination. So along with that program infrastructure, we do a comprehensive assessment of urinary catheter insertion and maintenance practices. So for your line insertions and maintenance, again, we're going to look at things very similar in program compared to the CLABSI aspects. So looking at the personnel who insert and maintain indwelling urinary catheters and then your auditing programs associated with that. So this is one of the newer ones that we've done. So there has been that one that we've done, but if you need us for this, please reach out and let us know and we'd be happy to help you. So now I'll switch it back over to Christine and she will close this out, and also we'll talk about our common themes with the HAI reduction project. Thank you, Chelsea. Appreciated that.
All right, so let's jump into CLABSI visits and common themes we're seeing. A lot of the issues with care and maintenance of the dressings, either the dressings not being dated per facility policy, occluded and or peeling, biopatch not applied at the insertion site, or not applied appropriately, just resting on top of the line and not being threaded through appropriately. Policies not matching practice on the units, for example, the scrub the hub, And we see a lot of the scrub the hub, them not following the appropriate time frame, usually a lot less than what they're supposed to be doing per their policy. Discrepancies in between different dressings being used. For example, if a facility policy says they're supposed to be using a CHD impregnated tegaderm and they're just using a standard one, and or a biopatch and tegaderm have to be used and we don't see any biopatches, those kinds of inconsistencies. Lack of ongoing competency-based trainings for insertion and maintenance, especially with residents and or providers. So that is a pretty common theme throughout as well. Also noticing, you see, for example, this triple lumen in the picture, going across when we see our observations, still coming across a lot of triple lumens, and in some instances, no justification. I did actually talk to a resident and they were never explained the risks of using a triple lumen, and thought that it was best practice to use it always, just in case you needed those extra lines. So it's important to have those conversations to make sure that the education is happening regarding the use of those multi-lumens and the risk. Next slide, please. Inconsistent auditing of practices, just to make sure that they're doing best practice. It's one thing to have a beautiful policy and have these trainings, but making sure they're actually still maintaining those practices and understanding, especially when there's new products and things coming into place, and or you have a high turnover rate of staff. We need to make sure that the auditing of practices is happening and we're carrying on those best practices. Inconsistent education around line education for patients and families. This is really, really important. It takes a team, right? We're all doing this together to take care of the patient and keep them safe. So making sure those patients and family members are educated on the importance of not touching, manipulating that line, having clean hands at all times, what a clean dressing should look like, any indications for them to let nursing staff know if there's an issue with the line, just making sure that that education happens. And also missing instances with hand hygiene and PPE non-compliance, not following up with staff appropriately, or providing ongoing education regarding those and the importance of it. Hand hygiene is the easiest way to break the chain of infection, but it's also the one that we see the most non-compliance in. So just reiterating the importance of that and how easy it is to do. Next slide, please. For device reprocessing, kind of switching it up a little bit here. These are some of the common themes that we're seeing. The IP annual plan doesn't include device failure prevention strategies. That's a really important part that needs to be included in that. Risk assessment for all areas that use semi or critical devices isn't being done. That means sometimes our outpatient settings can have semi or critical devices in those settings and we're not aware. So then we're not aware of them if they're being reprocessed appropriately. So we need to be aware of all those semi-critical devices that are being used throughout the system. There should be a list of those, and then making sure there's accountability and proper training for how they're being reprocessed. Lack of point of use treatment, case carts with visible bioburden. This is happening when, especially we're using that spray, they're not doing a proper distribution of the spray on the instrument before putting it in the case cart, and or heavily bioburden instruments, even with bone fragments and things on there and tissue, which is causing the SPD department, this processing department, to have to over manipulate those instruments and therefore put them at risk. So we need to be mindful that we're training our staff on the appropriate point of use treatment to keep everybody safe. Next slide, please. Some other ones we're still seeing is sterilization audits. Look at the PACs only, no audits for the actual HLD. Limited to no annual ongoing staff competencies for SPD and HLD. That competency part is really important for SPD and HLD to make sure that they're adhering to best practices, especially, again, as I've said, we're all experiencing changeover in our departments. We need to be really mindful that everybody is, doing best practice and up to date on what they're supposed to be doing and trained in those competencies, and they're skilled in the job that they're supposed to be doing because of the high risk there is just basically based on these instruments and them needing to be reprocessed appropriately. PPE not being used correctly by staff. The big one is no eye protection or mask being worn under their nose or under their chin. They might as well not be wearing it at all. The eye protection is really important in the SPDs because of the instruments they're coming in contact with, the detergents they're using and things. So we need to really make sure that they're using them and they have the appropriate eye protection in place. We have had some staff members think that their eyeglasses are appropriate eye protection, and that's really important that they're educated that that is not appropriate and not safe. Next slide, please. Unfamiliar with regulations around transporting soil devices within or to outside facility. This happens a lot, especially in the emergency department. This can happen where we can inappropriately put instruments in a baggie. I'm not putting any pre-soak solution on it. I'm soaking it in saline, which obviously we wouldn't want to do because that's going to degrade the instruments. They're not putting it in a biohazard bin to transport it. Biohazard bin doesn't have locks, those kinds of things. So make sure that you're looking at those instrument transport policy practices and making sure they're appropriate. Also, transporting devices in between facilities as well. Look at those practices and make sure that you have everything up to snuff and regarding following best practice. Loading washers, overloading them. Hinged instruments aren't being open. Those hinged instruments absolutely have to be open so all areas of the surface can receive contact. With the too full, the washers, what you can look for, those packages are going to have a lot of condensation, like water drops looking like on them, stains. That's one way to look at that to know if they're overloading them or not. We need to make sure those packages have room for all of the, sterilization and the steam to go all the way around the package fully for it to do its job. Overfilling packs, just cramming too much of those in there, that makes it very difficult for the sterilization to actually happen. Etching on instruments, that just creates another area for bacteria to live and grow in. I understand that the etching is usually done to have accountability for what department it belongs to and what area, but we've just created another problem that we cannot properly sterilize that instrument now. So please be mindful of that. Next slide, please. This is just an example. If you can see on both of these, well, first of all, these are both Pakistan instruments. That's the most important thing to gather from this. If you can zoom in on your screens, these are Pakistan instruments. These cannot be reprocessed, and they very clearly were because they're in pouches. So that's the first thing. These cannot be processed. They cannot be sterilized. They're the metal is subpar. It cannot hold up to sterilization. So these are one and done, right? The other issue is there very clearly is rust on these items, so they should have been taken out of circulation because of that as well. But the main issue is these are instruments from Pakistan. The metal is inferior. They cannot be reprocessed or sterilized. Next slide, please. So this is a shout out for our SHARP unit and wanting to share that we have some help for our HAI reporting collaboration. This is, remember, so our NHSN reporting for HAIs for long-term care is still, it's still just voluntary. It's not a mandatory option, but it's still voluntary. And it's really, really important, though, if you do choose to volunteer to report HAI reporting, it helps with us to know what's going out there, trends that are going out there, and helps to provide resources to help prevent. It helps give us a bigger picture of what's going on in long-term care regarding HAIs. So that's, when we have the underreporting, we can't really see what's fully going on. So that's why I want to put a plug for my colleague Sarmed and his awesome ability to be able to help you with your NHSN reporting, and plug this program for the HAI reporting and long-term care. There's a collaborative user group with peer-to-peer engagement. They get to share experiences regarding their HAI reporting and prevention. Real-time data analysis can happen with looking at your customized HAI surveillance reports, sharing data to help with each other, and help with your facility leadership, and then access to experts to help support, to have support and resources to provide help and aid in that HAI surveillance and prevention. So just know that I know it can seem intimidating to work, to the NHSN reporting. It seems like a lot, but you do not have to do it on your own. You have Sarmed. He can help you with this reporting aspect of it. He's really, really great at walking you through the different elements. He's a very good teacher for this. And it's a really nice program. So if you're interested in it, please, it's free. There's the contact information, and Chelsea has shared that in the chat as well. And I think that's it, unless, do I have another slide left? All right, there we go. Questions. Thank you everyone for your time. We really, really appreciate it. Please, if you have any questions, please go ahead and post them into the chat, and we'll be happy to answer.
Great. So we do have one question so far in the chat. Great presentation. Curious if hidden clinical disinfectants and hand hygiene were identified at all in IPRAT visits. This comes up frequently in long-term care due to resident safety concerns and the confusion as to what can be out in the environment.
Okay, so I haven't been seeing this as much. So Rebecca's saying, are we still hiding disinfectants and making it harder to access due to concerns that residents are going to ingest them or put them in their eyes or, have issues with them. I'm not seeing it as much as I used to encounter it before. There was a myth around at one point that it was, they had to do it because of regulatory and there was a risk to residents. When we have encountered this, we basically tell them to do a risk assessment to determine if there is, what associated risk there may be in their facility. But I'm not really seeing them hidden too much. I think the most common thing I do see is them being, not all of them, but the ones for the med card are being locked in the bottom, which also happens to be the only one closest for like lifts and hoyers and things to be disinfected. So that makes it for the scene is really difficult for them to access the disinfectant because it's locked in the medication cart, and it's usually in the med cart, so they disinfect the med cart. So that's really where I'm only seeing it the most. Hand hygiene products, not too often. I do hear more for us. I'm hearing more for aesthetic reasons why the lack of dispensers in the hallways. That's the most common when I'm coming across more. They want it to look more like a home care environment or a home environment, so they're not wanting to put them out in the halls, not from them hiding from the residents. So then when we talk about that, we do some education and try and determine a happy medium regarding that one, because it's usually often the owners that are really pushing for that aesthetic. But thankfully, I haven't encountered too much of that trend anymore.
And I think to go along with that question too, like what Christine said in the very beginning, recommending those risk assessments for the facilities to be able to have that documentation if it ever becomes an issue. And some of the things with hand hygiene, a neat idea that I've heard recently is putting it at a height where your staff can reach it, but it's not as easily accessible to the residents. So that could be another option as well.
All right, we have another question. Is there an effort to transition long-term cares from using McGear's to NHSN HAI criteria? How does that work with NHSN HAI reporting?
I'm not familiar with anything coming down the pipeline at this time. They are still treated separately because NHSN is unique to it because of the reporting purposes. And I can see if Chelsea has any other input on it as well. But for me, I'm not aware of anything. I do know, we do get questions about it quite a bit coming in through the inbox. But to my knowledge, they're still treated as separate criteria, one for the screening and one for the actual reporting of it.
Yeah, you're correct, Christine. I haven't heard anything either. For clarification purposes, that would be a great one to email to SARMED as well, to be able to get some more information.
Yes, my thoughts exactly. Thank you, Chelsea.
All right, another person says that they've used our services, and there have been a few times when a question is answered in the inbox that has led to really needing to have a conversation. Is there an option to speak to an IPRAT member to clarify responses?
Yes, absolutely. So, some of the time we may take it upon ourselves to reach out to you if it is going to be back and forth. And if you would like to have just a conversation, please, in the email, go ahead and say, if we had time to schedule a time for you to be able to talk, and it helps to be able to know your schedule too, so we're able to catch you during your busy schedule. But if you have a question in the inbox that you're trying to get, if you just want to talk to one of us, definitely put that in the request for the IPRAT inbox, and we'll be able to reach out to you.
Yeah, for sure. We love to be able to have the opportunity to discuss over the phone. It is a lot easier. We just never, it's hard to tell, because to get the tone from the email if that's what you want. So we're just trying to get you whatever information we can for you that we feel you need. But we definitely love to be able to have that conversation and be able to work through it more, because they're very nuanced. Every situation is very nuanced. So we are definitely here. We're at your disposal. Don't hesitate to want to be able to talk to us on the phone. We're here. We like it.
All right, another person came in a little bit in mid presentation, and so they were asking about the nipper slide. Did you say that nippers are a semi-critical equipment? Did you freeze up on me?
contact with intact or non-intact skin in the mucosal membrane, they do require high-level disinfection. There is a risk of a bloodborne pathogen. So they have to be high-level disinfected, which we know is a difficulty to do in long-term care settings. So that's why it's recommended to leave this task up to podiatrists.
All right. Well, thank you very much. We have on the screen our the toll number is our is 24/7, so it is answered by an administrative assistant, and then they can forward to the applicable person. We also have our IPRAT inbox and the website for you. All right, thank you for your presentation today. It was a pleasure to have you join us. We would like to say safe travels to all of you headed to conferences in April, and please mark your calendars for our next webinar, Hot Topics and Endoscope Reprocessing, on Tuesday, May 21st at 1 p.m. Eastern Standard Time. Later today, we will have the recording of this webinar posted up to our YouTube channel, and then we will also share a PDF of the slides on the APIC Great Lakes website, usually probably more like at the end of the week, because it does take a few days to have our webmaster have an opportunity to load that up for us. Do you have a job opening or an opportunity? Please share it to our job board. You can send it to our APIC's Great Lake Gmail, and we can pull it in and post it onto the job board, so anyone that has any of our members can have an opportunity to take a look at the job opportunity. And finally, I want to say thank you for joining us today. We appreciate you taking the time to come in and share and learn with us. And we look forward to either seeing you at an April conference or seeing you at our May webinar. Thank you.